Hello and welcome to the Mini Battles series by Athens Shoulder Course. My name is Manos Brilakis and I am the head of the organizing committee of this course that for this year has been cancelled due to the pandemic. However, being driven by our passion for continuous education, development and communication with our international friends, we came up with this idea to launch these monthly webinars dedicated to shoulder pathology and treatment, the Mini Battles series. Thus, we count down to the next Athens Shoulder Course, and we hope that next February we'll be able to welcome you and host you again live in Athens.
So let me welcome you also. I am Manos Antonogiannakis. I am the chairman of the Athens Shoulder Course. And so due to the fact that we had to postpone the Athens Shoulder Course for 21, we decided to have these mini battles every month. And so to have the opportunity to have two charismatic surgeons, shoulder surgeons, two surgeons that love the shoulder, and discuss with them topics that are hot topics of the shoulder every month and keep the Athens Shoulder Course active.
Today is the episode number 12 of the Mini Battles series, and the subject is concerning the tendon transfers. Before introducing our guest, please take a moment to vote in the following question. The question is, which is your indication for tendon transfer as far as the rotator cuff repair is concerned? And the options is muscle impairment, tendon impairment, both of them, or I don't use this technique.
So
take your time and we continue.
okay, so for this episode, we have two shoulder surgeons, very famous. Is Dr. Kany, a friend of us, and from Toulouse, France. And he's a specialist in tendon transfers. And also Philippe Collin, President or General Secretary of the SESEC, European Society for Surgery of the Shoulder and Elbow, and also past President of the French Society for Shoulder and Elbow Surgery. And we are going to discuss the topic of tendon transfers, indications, when to do, how to do it.
Thank you. All throughout the mini battle, you can also submit your question. And without further delay, let's the mini battle begin.
Okay, my dear friends, and thank you again to Manos and Manos for the very kind invitation. And I am very happy to debate with my very close friend, Philippe Collin. Tendon transfer, the only way to go. I have no any disclosure regarding this presentation. So the problem is what can happen when you have no curve. You can see here the partial isolated loss of elevation active in bracket. It is a partial highly, you say this patient, you can see this patient has some pain with his shoulder with good active motion, but lots of pain. And because of this pain, the range of motion is not correct. But the pain exists only in elevation, but not in external rotation and not in internal rotation, which are normal. On the other way, you see this patient has a pseudopelvic shoulder because he has no active elevation, but he has a good internal rotation and good external rotation. And this is the real highly described by Pascal Boileau. And now, this is the number 3 situation. You can see this patient, he has no pain, good elevation, but no external rotation and good internal rotation. The problem is the Hornbrough sign, and it's become a real problem when he wants to drink a glass of water or a glass of wine. And this is a real problem. And Pascal Boileau called that the Euler, isolated loss of external rotation. On the opposite, I've described a few years ago the Euler, the isolated loss of internal rotation. Look, this patient has some pain, good elevation, active, of course, good external rotation, but he has no active internal rotation, probably because of the problem of subscap. This is the Euler, the isolated loss of internal rotation. And you can draw a triangulation between these three different clinical situations: the plea, highly or partial highly, not the highly, but the plea, the Euler and the Euler. And if you combine two deficit, two directions like that, this patient has a combined loss of external rotation and elevation. This patient has a through paralytic shoulder described by Pascal Boileau. This is the clear combined loss of elevation and external rotation. On the opposite, I describe this patient with a combined loss of elevation and internal rotation. And for me, this is a true paralytic shoulder too, because you have two directions of paralysis, of pseudoparalysis, elevation and internal rotation, and you have an anterior and superior subluxation of the shoulder. This is, for me, a combination of two deficit, of two direction deficit. You can see no active internal rotation. So what can you do in such a situation? In case of partial highly painful loss of elevation, the patient is not able to elevate the shoulder because of the pain, but active motion is normal, and external rotation is normal, and insertion is normal. This is the type D of Philippe Collin. Of course, you can make a partial repair, but what's next? Because if you have already tried to repair the cuff, you cannot do anything after. What about the balloon? Of course, you can propose a balloon, but this what happened after 4 weeks, after 30 days. It's very flat without any biomechanical interest. You can propose a superior capsular construction, but it's not an active technique. It's just a spacer, in fact, like the balloon. So it's a biologic spacer, and you can propose a reverse rotoplasty. But what about for young patients without any arthritis? So for me, these patients are eligible for a lat dorsal transfer, and now today, a combined lat dorsal plus teres major transfer. The type D of Philippe Collin is for me the best indication of this double transfer. And you can see here this patient after 1 year. It was a failed previous rotator cuff repair with a supra and infra with a retear. And you can see here a very good result without any pain, with a very good active range of motion, both in internal, external, and elevation of the shoulder. So what happened for this patient? This is the Euler isolated loss of external rotation. It is the posterior cuff. So you can propose a partial repair, but the problem is, what about if you have any fatty infiltration, stage 3 or 4 of infraspinatus? What can happen? So I think it's probably not a very good result. And you can propose, of course, a balloon too, but look at this balloon. After 1 month, there is no water inside. It's very dry, and it's not possible for me to understand how it can work with time. So I think it's not a good idea. And now the SCR, but where will you attach your capsule? Because you have no posterior cuff. So it's not possible for me to use SCR. And of course, with a reverse, you cannot recreate the active external rotation. So for me, these patients are eligible for either a latissimus dorsi transfer, a lower trapezius transfer, or a Lepiscopo procedure. And what about the lower trapezius transfer? Of course, it is better than the lat dorsi if you want to recreate the external rotation arm at the body, arm at same position. But of course, it's efficient to external rotate the shoulder because it has the same direction of the infraspinatus. but it's very short and you have to put a graft, and this could create some problems. The lat dorsi on the opposite is stronger and better when you want to recreate the external rotation arm abducted at 90 degrees. And for this situation, I think the lat dorsi, of course, is biomechanically better. And the lat dorsi is efficient to elevate the shoulder. The lower trapezius is efficient to external rotate the shoulder. And now what about the isolated loss of internal rotation? In this patient, you remember this patient, so of course you can propose a partial repair, but again, what about your partial repair if you have a fatty type 3 or 4 fatty infiltration of the subscap? So sorry for the mistake, it's not the inspired spinatus, it is the subscap. You know what I think about the balloon and the SCR, why not? But well, will you attach your capsule? And superior capsular reconstruction is superior by definition and have to be fixed anterior and posterior to the shoulder. And again, a reverse shoulder arthroplasty cannot recreate active internal rotation. So for this, these patients are eligible for either a lat dorsi transfer but anterior to the shoulder and to the subscap. You can propose a pec major transfer. You can propose a pec minor transfer, but this transfer for me is too weak and too short, but it is published. So why, for me, the lat dorsi is superior to the pec major? Just because of the line of pull of the lat dorsi, which is very close to the subscap. But the pec major, as you know, is coming from the anterior part of the chest wall and cannot reproduce really the action of a subscap. So what are my results with full arthroscopic latissimus dorsi and teres major transfer? This is my primary report and it's not published yet. You can see here my experience since January 2008, 107 patients. And what is very interesting is more than 50% of my patients had been operated on for the shoulder before my surgery. So it was revision cases. It was not primary surgery. And you know that the results are not as good as the primary surgery. So this is interesting to see in the material series. And these are my results. You can see the different constant score, SSV, VAS, and so on. And you can see all the scores increased a lot after the surgery, after 3 to 24 months. And these are the details of my 107 patients with the constant score. And you can see that all the components of the constant score increase a lot. And this is the active range of motion. And you can see that all direction improved a lot, even the active external rotation ER1. Of course, the lower trapezius is better for this ER1, but you can see that it does exist with the lat dorsi. So what are my complications? And you can see here on the first column, the full arthroscopic combined lat dorsi plus teres major with 107 patients. And the column on the right, it is an arthroscopic assisted technique with more than 152 patients. First of all, the rate of hematoma and infection with the arthroscopic assisted and mini open technique. The second, of course, you can see that we have more neurologic complication with the full arthroscopic combined one, but it was the very beginning of my experience, and all these complications were transitory. After 3 months, there was not any palsy. And you can see that the rate of drainage and reoperation and revisions are much more important, significant with the arthroscopic assisted one. That means, finally, we have only 9% of complication with the full arthroscopic technique instead of 22% with the open technique, arthroscopic assisted open technique. So in conclusion, I think all this situation, the ILE, not the value, but the partial loss of elevation, the isolated loss of external rotation, or the isolated loss of internal rotation, that in only one direction of deficit are eligible for the tendon transfer, isolated tendon transfer. So the type D, the type B, and the type E from Philippe Collin. Thank you very much, and I am waiting for you for the next Le Mans shoulder course in 2022. Thank you. Thank you very much. Bye-bye.
Just a sec. I need to, yes. So first, I really want to say that I think in the world, and especially in France, we are a shoulder family. And it is not because we fight that we not get along very well. And I really want to say that Jean is a very good friend of mine. He will be the future president of the French Shoulder and Elbow Society. And I'm very happy about that. And we like to fight together, but at the end, we are very good friends, and I really love him. So I'm going to be very aggressive because it's a fight, and I want to win. So for me, tendon transfer works very well, very, very well, because you don't need it. That's why it works well. For this presentation, in order to be very clear, I will only speak about posterior superior tear. We could have the same debate for anterior superior tear, but because I would like to focus, and we're going to focus on posterior superior tear. So it's an interesting story, in fact. How does it start? It starts in many years ago with for the obstetric brachial plexus palsy for the children. And many years ago in the United States, in Ranchos Los Amigos, and they did that for children. Then Christian Gerber took the idea of to do this, the tendon transfer, in 1990, and he published it. So what was the goal? The goal was to restore range of motion, forward flexion, and external rotation. This was the goal. But some years after, big names like Janotti published that it doesn't work. It doesn't work. Patients with poor shoulder function and generalized muscle weakness prior to surgery, it doesn't work. That's what he said. And that's what Christian Gerber said. Said if you want to restore forward flexion and external rotation, both, in other words, if you have a pseudoparetic shoulder, tendon transfer doesn't work. So, okay, let's see the external rotation. If it doesn't work for forward flexion, let's see if it works for external rotation. So if you look at the paper from Christian Gerber, if you look not at the abstract, no, read all the paper and look at all the patient, and you will see that if you don't have, it works very well for external rotation, only if you have a good teres minor. If you have a good teres minor, it is true that the lat dorsal transfer works well. And it has been published in a systematic review that, of course, you can have some external rotation after a lat dorsal transfer, not so much, 10 degrees, not more, which is not a lot, especially if you have a good teres minor. But when you have no teres minor, it doesn't work so well. It has been published by Jean Kany and his good friend, and another good friend of us, Jean Grimbert, as you can see here, that it has been published that the patient had a higher risk of being less satisfied with their result if they had the following characteristics: teres minor atrophy. Interesting, very interesting. They all agree that if you have a good teres minor, lat dorsal transfer works very well, but if you don't have teres minor, it's so-so. What I have here, what I have published look at this, that paper. I think you know this paper now. I have published that if, sorry, I need to move this. I've published that if you have here no supra, no infra, in other words, if you have a good teres minor, then you have a correct external rotation, which is not a normal external rotation, but you have almost 30 degrees of external rotation. So for me, we've missed the goal, because the goal was to restore forward friction. It does not work. And the goal was to restore external rotation, but we have correct external rotation if you have a good teres minor. Just remind to you that here, in the type E, I totally agree. In the type E, you have no teres minor, you have no supra, no infra, no teres minor. And you can be very bothered by the lack of external rotation. This is true. This is a type E, no supra, no infra, no teres minor. And if you look at the result in the hands of Pascal Boileau, it's a very good name, then 50% of the patient had a persistent on-borrow sign after the lat-Dorsey transfer. It means, in other words, what does it mean? It means that you have 50% of failure. Now we have a season 2, because if something works very well, normally you keep it. No, they moved to another tendon transfer. And the season 2 is Bassem. Bassem, it starts exactly with the same story. You start with the brachial plexus palsy, then you publish your result on massive tear. But if you look in the paper, you can see that he has good results. That's true. But 20 out of 32 had good teres minor. That's why they have good results. Because if you have nothing, it works very well. So this is a case of a lady. Look, she has a pseudoparietic shoulder. She cannot elevate. You can see no supra, no infraspinatus, good teres minor, good subscap. Look, injection, rehabilitation. Look, forward flexion. I could have done a lat-Dorsey transfer for the same results, sure, and with a very good results. So tendon transfer, I agree, it's fun. We are orthopedic surgeons. We like to do difficult things, and tendon transfer is difficult. It's better to show that it's a wonderful technique rather than to show that if you do nothing, it works very well. I agree. And I'm sorry, I'm going to be a bit aggressive. But surgery can be the ultimate placebo, you know. It could be. And you know that, we know that in terms of placebo, more is better. If you do something very difficult, very technical, it's better. And it has been published for knee arthroscopy, for example, for meniscus, that they did the study very well, with a scar, with everything. It has been allowed in Australia. Then you can have a good effect of surgery as a placebo, because there is a lot of bias. There is the immobilization. There is a physiotherapy. I agree. I totally agree with you. I know that Jean has good result. He's not a liar. He has good result. I have to confess that if you have previous surgery, it's another story. Totally agree that if you have had previous surgery, each cases are different, and it's not my topic today. So in conclusion, teres minor, lat-Dorsey transfer or lower trapezius transfer works very well where the teres minor is still intact. But if you look carefully to the literature, everything works very well. Everything. physio, injection, rehabilitation, partial repair, long bicep stenotomy, balloon, everything works. Capsular reconstruction, everything works. And, sorry. But what are the take-home message? You cannot restore range of motion of a pseudoparalytic shoulder with a tendon transfer. I have 100% of failure. I did it because I love that, but I have 100% of failure. In case of massive posterior superior tear, if the teres minor is still present, for me, you can do what you want. Rehabilitation, long bicep stenotomy, partial repair, that's enough. You could say, do you have proofs for that? Do you have proof? Yes, I have. I have proofs. And I have proof that I've done with my friend. Sorry. We've published it. We've published that with Jean. We've published that the short-term results, and we've compared lat dorsal transfer to partial repair in massive cuff tear, and then there was no difference. And it was even a bit better in the partial repair compared to lat dorsal transfer. So thank you very much, and I'm happy to fight.
Thank you very much, Philippe.
Thank you for your nice presentation. Thank you once again. And before to start the discussion, let's see the second poll question. Which is your first step for the management of a posterior superior irreparable massive rotator cuff tear? You should select between debridement and tenotomy of long head of biceps, repair, tendon transfer, SCR, or reverse shoulder arthroplasty. As far as the first question, the participants answered that 20% have as indication muscle impairment, 10% tendon impairment, and 50% both of them, and 20% don't use this treatment option. So I would like for both of you a comment about this.
Sorry, I haven't seen the screen. I cannot see very well the screen.
Okay. The question was...
Is it possible for us to have a view on the screen? Because it's very small.
Yes. You can press over the screen and put the right button and put a pin. You can see big.
I'm sorry, Manos. I'm not able to read the screen too because it's too small.
Okay, I can read for you. The question was, which is your indication for tendon transfer as far as rotator cuff repair is concerned? And the option was muscle impairment, and 20% of participants said that this is the indication for them. Tendon impairment, and 10% of participants answered this question, and 50% answered both of them, and 20% don't use this treatment option.
Philippe, I don't understand what is tendon impairment.
Probably, I don't know, probably what has been published, by Christian Gerber when the tendon get into the muscles, and then you have no tendon anymore. Perhaps it could be this, but
okay.
I think that we agree together that for us, I don't want to speak for you, but I think we really look at the muscle and use a Goutalier classification. I think we agree on that.
Okay, yes, I agree with you, Philippe. If this is the question, I agree with the fact that if you have no tendon, for me, it's maybe a good indication for a tendon transfer, but the most important for me is the muscle belly fatty infiltration. After the stage 3 or 4, there is no indication for a partial repair for me. It's an indication for a tendon transfer. But you have no tendon, but a good muscle, maybe you can propose a partial repair. Maybe it can work. We know it works. The French Society has shown that.
So, can I ask something to both of you? Most of the patients that present with a rotator cuff tear are patients that they present mainly for pain and then loss of function due to the pain. And there are many options for this type of patients. And if we manage to lower the pain and then start rehabilitation, usually we have a good result irrespective of the type of treatment. But there is a category of patients that for me are an unsolvable problem or a very difficult to solve problem. And these are patients that they are not having arthritis yet, rotator cuff arthropathy, but they are pseudo-paralytic. And when we talk about pseudo-paralytic, there are patients that they are paralytic not due to pain. They don't have pain or they have very little pain. And their main problem is their inability to elevate the arm and external rotate the arm if they have a posterior superior tear. And this patients is a big problem for me because this is where we look at the MRI and usually there is atrophy of supraspinatus, infraspinatus, sometimes teres minor is there or is partially atrophied also. And this patient is a very big problem for me because whatever solution I tried, if we have an external rotation lag and without pain and also a pseudo-paralytic an inability to elevate the arm without pain also. This is a very difficult problem for me. And what would be your option for this type of patient? Philippe, Zan?
Philippe, I can answer first, or you prefer to answer first?
No, stop.
Okay. For me, we have to separate two different cerebral shoulder. There is the acute one and the chronic one. The acute one is a man of 60, 65 maybe, and after a fall, he has a cerebral shoulder. But after the fall, the shoulder was just perfect. For this patient, whatever you find, you have to try to repair the acute lesion. And most of the times, you will find an acute subscap tear and a chronic supra and infraspinatus tear. If you're able to repair the subscap only, then you rebalance the shoulder and your patient will recover everything like before the fall. This is the acute case of a cerebral shoulder. And there is the one you explained, Manos, the chronic cerebral shoulder. The patient has probably no pain, but no elevation and no external rotation. This is the clear defined by Pascal Boileau, combined loss of elevation and external rotation. For me, it's not an indication of an isolated tendon transfer. It's because it will not work, like said Philippe. It is a good indication for reverse plus tendon transfer, for example, episcopal procedure. So it's a combined surgery. Philippe?
Jean,
Yes.
I have a question for you.
Yes.
If you have a patient, like as you said, no supra, no infra,
yes,
type D, and a fresh, a traumatic tear of the subscap, you repair the subscap and it works very well.
Yes, usually when you have an acute tear, the results are much better. and usually they are acute on chronic, and then if you repair the acute part of the tear, then the patient is improved and improved a lot. But what happens to those patients that are not acute? Because the main problem that we are trying, as you said, Philippe, the main problem that we are trying to solve is the problem of the patient that is not arthritic and that he has an inability to raise the arm and external rotate the arm. And this happens without pain. Because if it's a pain and you solve the problem of pain, whatever you do, superior capsule reconstruction, balloon, partial repair, complete repair, whatever you do, then you are going to have and then rehabilitate the patient. You are going to have an improvement of the function also. But in my experience, when I had patients that they didn't complain for pain mainly, but for loss of function, these were the worst results in my patient. And this is the big problem for me, that the problem that is very difficult to solve. As you presented before, you said, okay, tendon transfer is not a solution, but what is then a solution in this type of patient? Would you propose a solution? What would you do in this type of patient?
I understand your question. I agree. I understand very well your question, but you should make a difference between action and efficacy, you know, because I know that in terms of when you are a shoulder surgeon, we think that sometimes if we operate, we are going to do something which is good for the patient. Sometimes I think that it is our duty to say that we cannot. We just cannot.
Yes.
Because I've tried, and we totally agree with Jean about that. If you have a combined loss of forward flexion and external rotation, which means if you have a true pseudoparietic shoulder. So first, what I would say, look very well to your passive range of motion. Most of the time, the patients, they don't have full passive range of motion. They have only 100 in passive, 150. And this small stiffness can be the problem of pseudoparietic shoulder. So you need to rehab and rehab and rehab again, injection. If you have full passive range of motion, passive, in forward flexion, in the 3 degrees, external rotation, internal rotation, and the patient is still pseudoparietic, for me, it's only in 2 situations. First, in case of no supra, no infra, no teres minor, type E, or no supra, no teres minor, no supra, no infra, type E, but with a previous surgery. For this kind of patient, for me, there is only the reverse. Only. I've tried everything, and only reverse shoulder arthroplasty is.
But Philippe, on a reverse plus or without a tendon transfer?
Oh, that's another question. Thank you for that. I need to show. Do you see me here?
Yes.
Yes.
If the patient is able to maintain like that, he has no external rotation, but if he's able to maintain here, just like that, and if you have a lag, but the lag stop here, I will not do a lat dorsal transfer during the prosthesis. If the patient is unable to maintain the arm like that, and is unable to do that to end to the month, then I will do a lat dorsal transfer with the reverse shoulder arthroplasty.
Yes, Philippe. In fact, we agree together for this indication. Reverse, of course, I agree. And the indication of a tendon transfer, I agree with your external lag sign. And this, I could say, depends on your design of your reverse prosthesis. If you lateralize it or if you make a bio-RSA, you can you have not the same indication what without this technique. So I can say yes for the reverse, and the tendon transfer depends on the clinical situation of your patient and the design of your reverse prosthesis.
I fully agree with you, Jean. I've done a study on that. I could present it to everybody next time. I've compared the Grammont design with the same the same lateralization on the glenoid side, but with a different lateralization on the humerus side. And for my patients, you can restore external rotation without tendon transfer, but if you lateralize in the humerus, not on the glenoid.
If you lateralize from the humerus and from the glenoid, or if you lateralize only from the humerus?
No, we all agree now that for the reverse shoulder arthroplasty, we don't know exactly the number, but it seems that around 6 millimeters, between 6 to 8 millimeters, is a perfect glenoid lateralization. That's what we think now. So on this side, and I think that in the future, everybody will agree that around 6-8 millimeters. You need to do that for impingement, for notch, for everything. That's going to be okay. Now our problem is the lateralization on the humerus side. If you have an only prosthesis, and if you have a curved stem, you are able to lateralize on the humerus side. But we don't know yet which is the perfect combination of the combined lateralization between glenoid and humerus.
Yes, probably this depends on the quality of the soft tissue. Both deltoid and the remnant cuff, the part of the distal subscap or part of the distal teres minor, you can keep it. But this depends on the quality of the soft tissue, I think. But maybe you are far from the topic. Manos, do you want us to comment something else?
No, okay.
Philippe, I have a question for you. Which is your indication for tendon transfer?
For me, I do some tendon transfer. For me, it's type E, no supra, no infra, no teres minor, with a true hornblower sign, and the patient is bothered. They cannot shave. They need to take the other end to shave. They cannot put the end here. They are really bothered. So for this patient, because for me, I always try to keep in mind the philosophy of tendon transfer. Tendon transfer has been performed for many, many years to restore a function. So, and you need to have same length, same direction, and in order to have a goal, and the goal is to restore a motion. So here, I have no external rotation. I want to restore external rotation. So I perform now inferior trapezius transfer, because as Jean said, it's better because it's a good direction. And some patients, but it's very rare. And we totally agree, in fact, because at the end, we have the same indication for trapezius tendon transfer. He does 5 a year. I do 5. He does 5 a year. I do 5 a year. Same. 5, perhaps 6. So in order to answer to your question, I believe in tendon transfer in order to restore a function. I don't believe in tendon transfer for pain. I don't understand how it works.
Philippe, may I can ask you a question for regarding? Yes, you're right. One tendon for one function. You're right. One same direction and so on, same strength, same. Okay, no impingement. But regarding the pain, in case of retear, in case you cut the bicep before, but and the patient still have some pain, do you consider that a tendon transfer could rebalance the shoulder? Just because you rebalance the shoulder, then you cut the pain. Because in practice, all my patients, the painful loss of elevation active after 1 or 2 or 3 previous procedures, you do a lat dorsal transfer. then you cut the pain, the patient has no pain and he can mobilize the shoulder. So I don't have any proof of my opinion, but my idea is this tendon transfer rebalance the shoulder. And because of that, this cut the pain after fail of physiotherapy, of course. What is your opinion regarding that?
So I don't know what you mean by rebalance, because you said that you have a good teres minor or not?
Yes, you have a good teres minor, but not strong enough after 1 or 2 years of physio and after fail of 1 or 2 previous surgery. You have 3 or 4 medial internal rotator of the shoulder. You have 0 or just 1 external rotator part of the teres minor. You rebalance the shoulder. You take 1 or 2 from the anterior. You perform fixation of the posterior part of the shoulder. Then you rebalance the shoulder. You have 1 or 2 internal rotator, and you have 1 or 2 external rotator. I think that sometimes the teres minor is not strong enough to rebalance the shoulder, because the goal of your physiotherapy without surgery is to rebalance the shoulder to reinforce or to augment the teres minor. If it's not possible with physio, then you put the lat dorsi, and this helps the teres minor a lot to rebalance the shoulder. This is just an hypothesis, of course.
Yes, so what I think is that sometimes we speak about one word, which is physiotherapy, but I think we don't look very well at what we want, and we need to ask very well to the physio. I want to reinforce the teres minor, to work a lot on the teres minor, and then if you work very well on the teres minor, injection, rehabilitation of the subscap and teres minor, for me, I don't see this patient. I've tried, but as I told you, when the patient has been operated previously, it's another story. And in this case, it's difficult, very difficult. And I don't understand how a tendon another operation, most of the time the deltoid has been injured, the acromion has been injured, and then you add another operation, and in my hand, it doesn't work. But I believe you.
Jean, I have a question for you. Which is, do you have different indication for latissimus dorsi transfer or inferior
Lower trapezius
transfer?
Yes, maybe it was not clear enough in my presentation because of a technical problem. For me, there is only one indication of it, because it's easier to understand in that way. There is only one indication of a lower trapezius transfer. It is the isolated loss of external rotation. So the patient has no pain, good elevation, but not external rotation. This is the Eiler described by Pascal Boileau, and this is the only good indication for the lower trapezius transfer. The other indications with an S are for the lat dorsi transfer combined with the teres minor, but this is my last evolution.
Okay.
So then you would say that there are patients that they are complaining of pain and they have some loss of strength due to the pain, and then to this patient you could do a latissimus dorsi transfer and so stop the pain and give some more strength to the patient.
Yes.
Is it so?
Yes, I think you have to cut the pain of the shoulder. Either you cut the pain with bicep stenotomy, either with a balloon or a CR if possible, if you have enough cuff to the back to fix it. But after fail of such a procedure, you can propose a lat dorsi, and the lat dorsi can work in such a situation. The strength will not recover, but the pain can disappear.
But Jean, in your series, you have only 50 patients with previous surgery. So why you did tendon transfer on the 50 other?
Yes, this is a good point, Philippe. Thank you. And Pascal told me I have to only to present my revision cases after a failed cuff for you to believe me. But sometimes, yes, I do an immediate tendon transfer in the primary indication. And I told you why. When I have a fat infiltration of a supra and infra, after a failed previous physiotherapy for more than 1 or 2 years, even if there is a good subscap and a good teres minor on the MRI, but you can have a very nice muscle with the MRI, but a very bad function. And if a patient still have some pain and with a fat infiltration, maybe without bicep, because sometimes the biceps have been torn previously. So when there is a fat infiltration, I propose a lat dorsal transfer for the first indication, because most of my patients say, so doctor, why do you propose two-stage surgery? And why not one-stage surgery? You try to repair. If it's not possible, you do your transfer in the same time. And as I have not a good answer, because you don't know if you just cut the bicep, you just repair, you make a partial repair, you don't know if it works well or not. So sometimes I decide to do both the techniques together, and I make my tendon transfer immediately, yes.
Jean, can I ask you something? There are some
Yes.
patients that they are operated, they have a massive calf tear, and then they have a partial repair or a medialized repair. And then after that, they don't have pain. They can raise the arm. They have good range of motion, active range of motion, but they complain of loss of strength. And their main complaint now, it's not pain, it's that not that they cannot raise the arm, but they don't have strength. Would you think that a transfer in these cases would be a good option?
No, I think it's a mistake to propose a transfer in that indication. No transfer can bring back the strength or the power. So if a patient has no pain, the tendon transfer will be useless just to recover the strength. I think it's a contraindication. The patient will be disappointed.
Philippe, do
Yes.
you use SCR for a posterior superior calf tear?
SCR?
Yes. Do you use SCR? Do you have indication for SCR?
No.
No.
For me, SCR, perhaps only one indication, but a very rare one, or very rare. When you have a very young patient, isolated suprater, with good teres, with good infraspinatus, good subscap, and fat infiltration grade 4 for the isolated supra, it's rare. On very young, for example, 40 or 45, perhaps in order to avoid an extension of the tear, to have something here, because side to side, sometimes it's not very good. You can have fat infiltration of the infraspinatus when you do a side to side. If you want to stabilize the situation, I do sometime, perhaps 2 or 3 per year.
Okay. And how about both of you? What about the pseudoparalytic patients? We have, on my opinion, we have not some option that have predictable result for pseudoparalytic patients, unless the reverse. But there are some publications that have very, very good results with pseudoparalytic patients. Can you comment on this?
With tendon transfer?
No, with SCR.
SCR.
Ah, yes. I understand. We need to agree on what is a pseudoparalytic shoulder. That's
Yes.
the problem.
Yes.
That's the main problem. I think that if it's a true pseudoparalytic shoulder, and what I think a pseudoparalytic shoulder, we agree in France, I think, it's less than 90 degrees of forward flexion with full passive range of motion, then SCR cannot restore range of motion. Or perhaps, as I showed the video, if they have a good teres minor, a good subscap, you can have a pseudoparalytic shoulder, because, and after a SCR, you can restore range of motion. I agree, but after a partial repair, you can restore. Same. Everything works.
Understand.
When we see the patients, our patients with massive calf tears and see the results, we have about in medialized repairs, partial repairs, and all this, we have about 80% good results. Satisfied patients. When I say good results, that means that they have active range of motion, not so good power, but they are satisfied for their lives they live, and they don't feel that they have a problem. But when we see the MRIs, we have less than 40% integrity of the repair. And we say that, okay, we do something, we change something, but we don't know exactly what we change, and we have this clinical result. This is, and as you said, it's rehabilitation, it's surgery, it's placebo, it's a lot of things that may work in this clinical result that we have at the end. And now, as I grow older, I try to operate more patients in the acute phase, because in the acute phase, when you have an acute problem, the results are usually much better. And also when you have small or medium-sized tears, then we know that we can have a repair that is going to remain and not fail. And this will change the natural history of the rotator cuff disease, let's say. But as the patients grow, as we go to more chronic patients, we can do a lot of things to stop the pain, to restore also the motion if the problem is due to the pain. But when we go to really pseudo-paralytic patient, that for me it's what we said, but plus a patient that is not complaining mainly for pain, but mainly for the loss of function. This is a very difficult problem for me, very difficult problem to see. And the results, when we do tendon transfers and we have an external rotation lab, usually what the best that we can do is to have the external rotation at 0. And when we have this external rotation, from this external rotation, then patients usually are satisfied because they can do a lot of things, but we don't have active external rotation in most of the patients, that at least in my practice. And it's a difficult problem for me.
Zan, the obesity changed your plan for a tendon transfer. In obese patient, the exposure of latissimus dorsi is more difficult than lower trapezius. Do you take it in your mind, or you cannot affect about the
so far this not affect me, as I make it, as you know, with a full arthroscopic procedure, and obesity is not a problem at all, because you are already on site, in fact, and the surgery is not more demanding than for a dry guy or dry woman. But when you make an open procedure, yes, this could create some problem and hematoma and infections, of course, and because the skin under the vascular field is a very bad quality, especially with men and obesity, yes. But arthroscopically, there is no difference.
Okay.
But I don't have the answer, but this is another point. I think, but I have to look at my data. Probably the results are not as good as with a dry guy, maybe because the weight of the arm and maybe the lat dorsi is not strong enough to counterbalance the weight of the arm. I'm not sure. This is just an impression.
Okay. Philippe, you referred enough to the physiotherapy. We have a question from Sebastian Travers. From what period of physio you choose to do a transfer surgery? Do you send the patient to the physio for a specific time period or not?
At least 6 months.
Okay,
Philippe, it's very important you answer, because Sebastian Travers is my physiotherapist. So please be clear. Because tomorrow morning he will ask me, hey, Philippe Collin is not agree with you.
I think it's 6 months, and now I use more and more shoulder pacemaker, even for other indication than posterior subluxation. And I think it works well, especially for teres minor.
A pacemaker?
Yes, shoulder pacemaker.
Shoulder pacemaker.
You use it for physiotherapy on TRs.
Yes.
Okay. And how it works for TRs? Because I thought that it was for posterior instability.
It works because you can focus the physio on one for the teres minor, for example.
Okay.
So you use it as a biofeedback for to increase the strength, to make the patient more conscious of the function of the teres minor.
Exactly. And to reinforce it.
And what is your experience about this?
For this,
The results. How was the results?
For the type D, for my patient, first patient, never been operated on, no previous surgery. I almost never perform surgery for this patient.
Okay. Okay. It was a nice mini battle. And before we say goodbye, we have the results from the second poll. And the participants answered that 60% do debridement and biceps tenotomy, 50% do a rotator cuff repair, 70% made a latissimus dorsi transfer or a reverse, and no one answered for RSA. So next month we will have a discussion about transosseous repair or anchor repair, and this will be in the 15th of April. And now we are in the end of this mini battle, but before leaving you, please complete a tiny questionnaire. And thank you once again for attending. Thank you once again, Jean and Philippe, for participating in this webinar.
So thank you, Philippe. Thank you, Jean, from me also. It was a real pleasure to have you here. And I really hope that we are going to have both of you in Athens to have a real battle and then real wine after that. French wine.
Okay.
French wine.
Okay.
Thank you.
Thank you. Thank you very much.
Thank you, double Manos. Bye-bye. Ciao, ciao. Salut, Philippe. Merci.
Salut. Follow me, net because